My name is Allison Carroll. I'm doing my Grand Rounds presentation. Here is my badge. So I am presenting to you guys from here in Palatka, Florida, wanting to share a recent encounter that I had with a very pleasant 79-year-old white female who came in with multiple diagnoses, comorbidities, and complaints. So at the end of this presentation, you will be able to identify signs and symptoms of urinary tract infections in the elderly population. You'll be able to identify signs and symptoms of severe sepsis, create a treatment plan for sepsis, and discuss how to treat patients who present with sepsis and other comorbidities such as congestive heart failure. The chief complaint of this patient was weakness, fatigue, and urinary symptoms. The patient was brought in by EMS. Her neighbor went to check on her, said she was feeling a little off, not from her baseline. She was a little altered, so they brought her in. She'd been complaining of urinary symptoms for 3 days now. She states that it feels like it's a burning sensation when she tries to urinate, accompanied with urinary frequency, weakness, altered mental status, fatigue, urgency. She states that these symptoms started about 3 days ago. They're consistent all day, all night. The only relief she gets is when she takes Azo over the counter at night, which helps with the urgency and frequency. And the burning is about a 5 out of 10 on the pain scale every time she tries to urinate. And just to give you a background, this patient was actually in the hospital a little over a month prior for similar symptoms, urinary symptoms, as well as a touch of pneumonia. So the patient has a very extensive past medical history, including CAD, hypertension, congestive heart failure. She's a type 2 diabetic, anxiety, depression, GERD, kidney stones, stage 3 kidney disease, seizure disorders, TIA, and chronic back pain. She has a surgical history of a cystoscopy with stent placement for kidney stones, cholecystectomy, cataract surgery, left ankle fracture repair, and scalp cyst removal. She does have a diagnosis of anxiety, depression. She takes Zoloft every day, denies suicidal ideation at this time, and feels safe at home. And for her medical history, for her family, she states that her mother died of a stroke, had hypertension and heart disease as well, but was unable to tell us the history of her father. The patient's home medications include Endure, metoprolol, and Norvasc for her hypertension, baby aspirin for recent TIA, glyburide to manage her type 2 diabetes, Prilosec for her GERD, Keppra for her seizure disorder, which she says she hasn't had a seizure in over a year, and Zoloft and Restoril for her anxiety, depression, and difficulty sleeping. So upon my physical exam with this patient, I noticed that her oral mucous membranes were very dry, pale. She had a general pale appearance to her. She looked like she hadn't been taking care of herself. She was incontinent of urine. With her breasts, listening to her lungs, they were very diminished but clear. The patient's urine was very yellow, cloudy, sediment, had a little bit of an odor. And like I said, she was incontinent at this time, which normally she wouldn't be. She was a little bit of a poor historian. She was alert to herself, the situation. She knew she was in the hospital, but she didn't quite know the severity of her symptoms. She couldn't tell us the right date or time. So she's a little bit altered, poor historian. We had to get a lot of her history from her past medical records. So her vital signs showed she was febrile at 100.4 degrees Fahrenheit, hypotensive with blood pressure 96/52, which she's probably, with all those hypertension medications that she's on, 96/52 is probably pretty low for her. She has a respiratory rate of 17. She's 95% on room air, and she was tachycardic with a heart rate of 117. So the patient had a lot of diagnostic tests already completed in the ER by the time Dr. Abani and I was able to see the patient, including a CT of her head, which was negative and unremarkable. She had a complete white count, which showed an elevated white blood cell count of 12.9. Her complete metabolic profile showed she was hyperglycemic with a blood sugar of 329, elevated BUN of 42, and her creatinine was 1.86. Which, looking back in her previous medical records, she pretty much lives with a creatinine about 1.5. Her lactic acid was elevated at 2.6, and her urinalysis showed she had a pretty extensive UTI with the occurrence of extensive white blood cells and red blood cells. So my preceptor, Dr. Rabani, and I came together and ordered a few more diagnostics before actually admitting the patient to the hospital, including a CT abdomen to check for kidney stones. She has a history of kidney stones. And being in a small rural hospital, we don't offer urology services. So if there was an extensive stone, we would actually have to ship this patient out. So that was something we had to check before admitting the patient, which luckily it was negative. And we also ordered a pro-BNP and troponin to check her cardiac markers. Her pro-BNP was elevated at 2,403, which showed she was a little bit on the fluid overload side, but she wasn't in any respiratory distress. She did have about +1 edema in both her lower extremities. So with this patient, we gave a couple different diagnoses, first being sepsis. She met sepsis criteria with the elevated white blood cell count, elevated lactic acid. She was febrile, hypotensive, which initiates our sepsis protocol. She has a urinary tract infection with a positive urinalysis, a history of recurrent UTI, and E. coli bacteria in the urine. Metabolic encephalopathy with the presentation of altered mental status, increased lactic acid, and sepsis. Had uncontrolled diabetes. We checked her hemoglobin A1C. It was 11.7, suggesting that her daily glucose was around the average of 289. So those are our 4 differential diagnoses for this patient. Our treatment plan included the sepsis protocol, which is a big protocol that includes fluid resuscitation, 30 milliliters per kg, insertion of 2 large IVs, blood cultures, 2 IV antibiotics, which were ceftriaxone and doxycycline. We ordered follow-up lab, CBC, CMP, lactic acid, Tylenol for her fever to keep it less than 100.4, and a follow-up urine blood culture to see if it is truly E. coli or if maybe there's a different bacteria growth in her urine. For her metabolic encephalopathy, we just ordered frequent neuro checks. We want to monitor on telemetry, oxygen if needed, control her fever, follow up on her lactic acid level. We also wanted to order a physical therapy and case management consult to evaluate her needs for after she is discharged from the facility. And for her diabetes, we're going to hold her glyceride and order sliding scale insulin to see just how much insulin coverage she needs for a 24-hour period. And educate the patient on the importance of controlling her blood sugars with the multiple comorbidities, heart disease, CHF, kidney failure that she's already experiencing. The uncontrolled diabetes is only going to make things worse for her. So just a little bit of a reflection of what I learned with this experience. So the patient has congestive heart failure, and with the sepsis protocol, we would have to really fluid resuscitate this patient in order to reduce the risk of mortality. However, with someone with congestive heart failure, you could further damage them by putting them into respiratory distress and fluid overload. So my biggest concern with this patient was trying to figure out what the appropriate amount of fluid resuscitation would keep her from becoming more septic, however, keep her from going into respiratory stress and fluid overload at the same time. So one compromise that I was taught was to just simply slow the fluids down. Instead of bolusing over 3 hours, we bolused over 6 hours, and were able to reevaluate the patient after her treatment and found that not only was she not in any kind of respiratory distress, but many of her symptoms had already begun to resolve. She was already more alert and oriented and reoriented to herself. She was already a better color. Her fever was resolved. Her lactic acid was now less than 2. And her kidney function had improved a little bit to 1.7. So it's really great to see these efforts make a difference in these patients with sepsis, and how making such a fast and appropriate measurement to treat these patients quickly can really reduce the risk of mortality, especially in the elderly population. They can turn so quickly. I look forward to your feedback. Let me know if you have any questions. Like I said, this was a really good experience for me, and I hope you think so too.